Hello, everyone. We are doing our first podcast series uh, for neurophysiotherapy update. And for this series, our theme is bias in clinical decisions. There are more than 100 biases have been identified in clinical decisions when clinicians make decisions about the choice of treatment or diagnosis. But we have selected few important biases that are very common that has a major impact. Today we are going to discuss about action bias. We have with us Mr. Hariom and we're going to discuss with him. Welcome, sir.
Hi.
Okay, so today the bias what we are going to discuss is action bias. Now, action bias means we have a bias towards taking an action, that is that we want to take action all the time. That is in a clinical setup, it means sending patient for investigations or doing it that is doing a particular test or giving a particular treatment for any problem patient come up with. Now, at the outset, it may appear like what's wrong in it. Of course, if the patient comes when we have to do a test and give a treatment, but should we always take an action or giving a treatment is always the right choice? That is what this action bias is all about. Um, okay, so what are your thoughts on action bias?
No, I'll just start from the beginning, I suppose. When you go to college, the first thing you learn is that you're treating everybody, you're curing people, you're managing people. This is in any health professional, whether it is therapist or TPT, clinical psychologist, or neurosurgeon, or anybody. So we have this inherent need, and it has been, which is already in us, in human beings. Inherently, there is a need to do something, and which is amplified by college education. I think that's the root cause of all evil, I suppose, is the college education of doing things, because he has come to us for treatment, for help, and we are there to be the savior and change his whatever it is. So that's the crux of the problem, and I think this where we have our it's all right if we have the best treatment. I suppose everybody wants to do it. There is no mistake in it. I think the problem comes when a self-healing structure, a biological structure, when we can't understand whether it is healing by itself or when we have done something to heal it, that is where the whole problem starts.
Right. So in this, when trying to understand action bias, like I said, it's counterintuitive not to take action, right? But uh, if you get a little bit in depth into it, in many cases, not doing anything is an appropriate decision. Before getting into why, let us look at what are the reasons that why we feel tempted to take action or why we always feel right to take action. Now, in literature, quite a few reasons they've identified why do we prefer action over inaction. One of the common reasons they tell us that as a society, we view inaction as something wrong, that he didn't do anything, that's something wrong. That is one of the reasons people think that now that the norm is to take action, not doing so. As we live in a society, we always in a default mode is to do something about it. That is one of the reasons they identified as common reason for preferring action over inaction. Other reasons are we always try to be, or we have this need to be in control. So taking action also make us feel that we are in control of the situation. Whether we are actually in control or not, that's a different thing, but it gives us that feeling, a certain level of confidence. The third reason that they have they're suggesting is that we tend to overestimate the benefits and underestimate the harms. That's the biggest
Right.
reason that why we are want to take, because of course there is some kind of benefit in action, but there are harms in it we tend to underestimate. So what do you think about overestimating benefits and underestimating the harms as a reason for action bias?
No, no, I also think there is a, just before that, I'll just uh, put my 2 cents also in it. One of the things I think is also because evolutionarily, if you think of ourselves being hunter-gatherers or the early farmers or something like that, if you just sit back and if there was some sort of danger lurking in, and when you're into the bushes and the bushes are shaking, and if you just thought that, okay, nothing will happen and I will just sit around, if it were becomes a, I mean, your unlucky day and it was a mammoth or a tiger or something like that, you would be eaten. So doing something, even if we are wrong, um, is actually evolutionarily very, very important for us. It's all right to be have a false positive or a false negative. If you are wrong, that's all right for us. But at
So
the same time,
basically, I just wanted to ask that you're saying that it might be, it's evolutionarily we have developed as an intuition that's ingrained in us.
mm,
But this is just my thought, is that
mm,
that seems to have some value when a person has to take a decision for himself. But
mm.
in clinical decisions, that we are taking decisions for others. So, but at the same time, we are still taking action. Are we trying to protect ourselves or trying to protect patients?
No, you're right. Even if it is for the societal needs, say for example, you are the leader of the hunter-gathering group, you make the decision for the whole group, right? And so it's not just you are the whole thing. It is the whether the problem is a known or an unknown problem,
Yeah, yeah.
right? If it is a known problem, I can have an idea about what are my options and what can be the outcome if I do something, if I don't do something, and things like that. But if I don't have a idea what is the danger, say for example, if I don't have the slightest clue what is behind the bushes, then it is always better to do an action. But here, after millennia of evolution, uh, we know a lot of things about the problem and the possible outcomes. So we have a better chance of doing a intelligent or a educated uh, decision rather than just doing it uh, intuitively or something like that.
I think action bias also helps clinicians to help them deal with this uncertainty. That is, if you're taking action means that, again, it gives you some control or a sense of control that you have over situation. So if I have to understand what you mean, what you're meaning by having the knowledge of what is the likely outcome of the decision. So if clinicians start recognizing the uncertainty in the outcome of decision, so do you think that might in some way help to minimize action bias?
I'm not sure because what it tells us is that uh, it gives you the illusion that you are in control of the outcome.
Yeah.
That is, uh, okay, I have done something. You are just standing there. Even though if somebody is falling from 10th floor, if you are putting your hand out, it doesn't help at all. Uh, Actually, they may actually break your hand. You both of you might suffer. But we know that we are trying something. So there is an innate feeling that I have tried something, and you are just standing there, that kind of thing. But as I told you, there is a difference between, say, for example, trying to put the brake and not trying at all. That's a different situation. But here we know that in biology that something happens by itself in many conditions or in many situations. That is, it goes to the equilibrium, it goes towards the normal, it goes towards the homeostasis, whatever word we use. So I think we actually read that, but we just don't follow it, or we have that split in our mind. We just don't follow it. The simplest example, if people are very confused, is if you have a pediatrician and if you take a child with a cold and sort of mild fever, and if he gives you a treatment, he's an idiot. He should tell you to, uh, he should give you a good education. He should make you less anxious. He should tell you that in 2 3 days, if something, everything will go back. Uh, just have to wait it out until that time. You do some simple homemade remedies, that kind of things, right? So because a lot of people have said that no, 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 we want to do something and make it better, 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 better. We know that we have ended up with antibiotic resistance. The whole of abuse of antibiotics starts with an idea that uh, at least I tried, from that idea of at least I tried to do what? In reference to what?
Yeah, the recent example for why action can cause harm or I mean large harm is remdesivir for COVID, right? Because despite having clear evidence, not like unclear evidence, people have no both sides. Despite having clear evidence that remdesivir has no role in any of the outcome, whether it's going to prevent death or reduce severity or whatsoever, this is everyone, I mean, the doctors and experts, everybody recommended it, which has led to acute shortage. A lot of people spent money. Some of the people whom I've known spent like 10,000 and 12,000 rupees for remdesivir doses. So much of money. We can't simply, of course, why they all did it, because they thought it can do something, except that it cannot. So this is one recent example of why inaction is actually good. Again, here inaction means not allowing patients to die, but waiting for things, because there is no other option is there. We could have saved a lot of anxiety, and this we have this rumor going around. Social anxiety has been spread around. Governments were forced to act. So much of damage has been done despite knowing that it doesn't work.
Yeah, and also if you uh, look at the alternate,
Yeah.
say for example, when I told about the child, what do you do if a child has fever? Show us love and give a lot of fluids. That kind of thing is the alternate. The alternate is not just look and just see the patient. It is active observation, active monitoring of the patient. A lot of people don't understand that monitoring is it's an action, right? That is also very, very vital. You just wait and be very, very, uh, they say you put your eyes on the patient so specific. even if there is a change in the oxygen levels or things like that, just keep on monitoring. That is what is the alternate. The alternate is not just thinking of, okay, let him
Yeah,
die. We are not talking like that, right?
that's a common misunderstanding, isn't it? When we say inaction, it just means that okay, let God take care of it. It doesn't mean that. To be
Right.
to decide not to do something requires a lot of intelligence and their ability to think and take a right decision. It is not just about closing the eyes and just let nature take its own course.
Correct. If you're playing cricket, if you hit the ball up, it's
Yeah.
going to come down. There is no, you don't have to jump there to go and get it. It's going to come to you, right? You just have to wait for it. I'll just add on the common action bias we have in physiotherapy. The first and foremost action bias, that's what I had, and I think everybody has, is any element lesion and electrical stimulation.
Yeah.
We think that
People
if
ask,
you do
what
that,
what what will you do in early stage? What functional training? Nothing can be done. When nothing can be done, then what
correct.
can do? That's the common question people ask.
Well, so we are not asking the question, uh, okay, you are doing something to do what?
Yeah.
What are we expecting from them, right? And this is where I think we are going to have a clinical meet tomorrow, and we are going to talk about recovery. We are not, we don't know what is recovery in a sense. We don't know what we are expecting. We are throwing something and thinking that something will come out of it. And what is that something? Most of the time, we don't have a slightest
And
clue.
also people don't people think that they're doing something, but when you're giving electrical stimulation, whether it's LMN or UMN during acute stage, it can actually contribute to harm to recovery because in a way
Yeah, sure.
promoting patient remain passive. It includes for whether electrical stimulation or passive movement, anything we do. We're just telling the patient without telling that you just have to lie down. So this can be
Yeah,
really, really detrimental to recovery.
yeah, exactly. And the it's the it is that kind of thinking which is prevalent not just in uh, just one part of physiotherapy, it's everywhere. uh, Again, going back to the COVID example, if you think of hacking, clapping, and breathing exercise and all those things, uh, it's all just a waste of time. But we all want to show that physiotherapy is here for who, I don't know. I understand probably we want to feel as though we are part and parcel of preventing the pandemic. And sadly, some of the people in Tamil Nadu also went and said that we will reduce the oxygen need if you have. It's all well and good, but there is there is nothing to show to that it actually happens. So if you have not done any of those things in the ICU, uh, nothing would have happened. So what I'm trying to say is sometimes what happens is we have an action bias, and that action bias is stopping us from looking for other
Yeah,
alternates,
exactly. That is
right?
what is the key problem, that if we always work in a default mode, that is what comes first to you, where you are, the action bias is stopping us from considering alternate options. So action bias doesn't mean that don't do anything, but there can be
Mm,
very well important options are there, but it stops us from considering. I just want to clarify because we use the word bias a lot, but I think there's a lot of misunderstanding about the word bias, because in general
yeah,
terms we say somebody is biased because he's favoring one person over another,
yeah,
so on.
yeah,
But it's not that kind of bias. When we talk this
yeah,
cognitive bias, it is unconscious.
yeah.
Common bias, we say that somebody is deliberately favoring favoritism, and that's not the bias we're talking about. Most clinician
Uh,
doesn't
I,
really know.
And also, I think you cannot take away any of our biases
Yeah,
in our clinical decision making, or even in any of our life. We can just be careful about it. These bias, because it's unconscious, it will creep in.
yeah.
The only thing we have to be is we have to be aware that all our decisions are based on some sort of biases in our ingrained in our thing.
Yeah, exactly. We need to understand that this bias, having knowledge about bias, doesn't take away bias. Say, for
Yep.
example, I'm sure I have action bias too, or
Yep.
he is also action bias, having action, because we are humans. The cognitive bias, or
Yep.
in a way, it helps us, but since we
Yep.
have evolved along, that some of it, what was helping us, is now it's becoming a problem. But having
Yeah.
the knowledge over bias, it makes you self-aware. When you're taking a decision, you might want to check, okay, am I doing this because it's the
Yeah.
right thing to do, or am I doing this because I feel better, and I want to be in control? That way we can minimize this bias. That's the whole idea about it. We can't just take away bias from us.
Correct. That's
So
why
one
I
has to
thought.
become like a Zen uh, Buddha to
Yeah,
take away
yeah,
all.
that's not going to happen.
Yeah, that's my other way of
Especially,
saying that it's not going to happen.
yeah, and also if you have a child, there is never going to, the action bias is never going to go away.
Yeah.
You are going to they do something to your child to make him study better. Most of the time, just useless thing, right? It just feels as though I have done some parenting. Likewise, I think it feels as though we have done some therapist or something. Um, and the other action bias I think is in doing a lot of tests. Uh, that is the sort of a broader sense.
In doing what?
Whether it is a lot of tests,
Okay, test. Okay.
right? Whether it is X-rays, MRI, whole of
Well,
the
test.
Maggie book on a patient to find out this or that, to be thorough, that kind of things. Because we all know that these tests are not 100 percentage. So the more the test you do, more findings you will get, more nonsense we are going to do to our patients. And also, a lot of times I see this in back pain and ONE and things like that. They come and say, no, we took an X-ray and it's all good. There is nothing a problem. And we took an X-ray, MRI, and we found out that this is. That's all well and good. Did your ortho change the tablet? It's all the same NSAID or opioid or some other crap which is pumped into it. Uh, it's also the same with physicists also. What did you do with an X-ray or what did you do with the pathology most of the time?
Okay, this
Answer
example,
to those
I think it brings to my next and the final question, is that the action bias is not just clinicians' involvement, it is also the patients who
Yep.
want actions to be taken. So I'm sure many of our listeners, this question might have already has come, that even if we say no, the patient insists to take action. So how do we deal with that?
Some time back, I asked a question in the Facebook, what is a consultant? Right. Uh, Now, a consultant uses or impacts knowledge on a problem,
Yeah.
impacts that knowledge and sort of gives a solution for that,
The
makes you
choices,
aware of the problem.
options that are available to take
Correct,
action.
correct. Uh, and also makes you understand about the
Yeah.
whole, whole problem also, right? You get a consultant for the alignment of the train tracks, in which way the tracks could, which areas it should go, whether there is road there, that kind of thing, right? So when you see a consultant or when you see an expert, or I'm talking expert as any person with a medical degree,
Hmm.
with a BPT, MPT, BOT, or anything. Now, what they are asking you is what should I do? They are not asking you do something. They
Yeah.
are asking you what should I do, right? So if you see in that way, what should I do? The patient is asking me, what should I do? Then the answer will be clearer. If
Yeah.
you are thinking they have come to me to do something, that is where we are all in trouble. And if you are a consultant, proper consultant, if it goes higher and higher, they tell you the problem, they make you understand, and they. So if we have that change in our attitude, half of it will be okay.
Yeah, exactly. That is what even the another Facebook share which I have recently done is that where a patient asked for an electrical stimulation for a lower motor neuron lesion
Mm.
because he received in previous places. So when he
Right.
asked for it, I have politely refused an electrical stimulation, saying that exercises is. I basically told him that exercise is what you need. That is what is having a higher benefit, and receiving electrical stimulation, your recovery chances are very poor. Right.
Mm.
And the patient again. The thing is, sometimes when we explain patient, we are saying it in a moment. At that moment, patient doesn't think and come to okay. They won't. They
Yeah.
sometimes they might not even be listening completely. So after within the second, he kept insisting that previously I have had. Why don't you give and so on. So I've made him an offer. Okay, okay. If you're very insistent, I will give, but give me 2 weeks time. You take this
Right.
for a couple of weeks. If no
Mm.
changes happens, then let us consider
Mm.
your options too. So that made him
Right.
think that okay, we are just not saying no, we are also considering his views, even though I
Right.
disagreed, but it is his preference. But it's a sort of
Right.
negotiation what we have had. And in this case,
Mm.
actually, patient he started feeling better as he started walking and move on,
Mm.
and then eventually he stopped
Mm.
insisting, and it's a positive experience. And I'm sure in some cases it may not be as positive, but we needed to be able to communicate effectively, not to think that patient won't accept all the time, even though like
Yeah,
some
exactly.
won't accept, of course, yes, but yeah.
No, no, I completely agree. I have a lot of patients who have not agreed with what I have told them because they had their own biases, which was incorporated probably from the childhood, also from the uh, physician or surgeon they saw before me, right? So this is not a black and white issue of okay, we have to go here or there or something like that.
The point
But at the same
what
time,
once again, the point here what I think people have to understand is that not every patient would go away.
yeah,
We need to understand that there is a lot of patients who can actually listen. Just because one or two patients of yours gone away, you don't have to shut up
yeah, exactly.
your clinical practice. Doesn't end up. Some people are anxious that it always happens. I mean, I'll have to stop my practice and so on. You get different kind of patients. That's all which will happen. You develop different kind of image. You will get that kind of patient who would really want to
Yeah,
listen.
exactly. And also, there are uh, the one of the problems in this is we keep on thinking that if we come 10 days or 20 days, then only it gets better. So again, it's not just a problem of mm, the knowledge or anything else. It's just that the tradition of the 10 days therapy has made us feel that if we don't take 10 days treatment, if they don't come every day, if they don't come without fail, then only they will get better. I think these are the things which we can easily change before getting into what will I do out of 10 patients, 2 patients are not listening to me. What shall I do with them? First, we will try with the 8 patients, then we'll go to the 2 patients.
All right, so I think that brings the end of our discussion. So just to summarize, we have discussed the action bias, and do not mistake action bias for not taking any action or just taking our hands off and so on. But it is about not always act on a default mode and consider alternate options and choose better options. And as Mr. Arium was pointing out, if we have to truly act like a consultant, an expert consultant who explains the problem, who unpacks the problem and explains what are the issues, what are the probable causes, and what are the available solutions, and also what is the best available solution given the context, given the patient, and help patient make decisions. It is true that some patients may insist you make a decision, or it is true that some patient may not accept the decision that we are taking. But the thing is, it doesn't have to be. I mean, every patient need not say, and we are having a lot of people who practice this way. So don't think that we are in the minority who practices this. Quite a lot of people have a very successful practice too. Just that we are worried, concerned that it might not work. But to the betterment of our patients, we should start considering alternate options and choose the best one. Do you want to have any final?
Yeah. I just want to re-emphasize that healing happens by itself. What you're doing is managing the discomfort, managing the environment, the microenvironment and also the macro environment in such a way that the healing is promoted and they are in little bit of as little as discomfort as they are. You are not healing the patient. Remember that most of the time.
Okay, thank you everyone for listening. Let us know how do you like it. Bye bye.
Bye bye.